My name is Alexandre Marra. I am professor of the Pós-graduação Stricto Sensu program in Health Sciences at Albert Einstein Instituto Israelita de Ensino e Pesquisa, and also I am a researcher at Hospital Israelita Albert Einstein. I have been doing research at the University of Iowa Internal Medicine Department in Iowa City for almost 7 years. I'm really excited to introduce one more presentation in the Einstein Connection series of guest speakers. Einstein Connection is our international program that intends to connect Brazilian researchers, students, and healthcare personnel with international professors and international researchers. It's my pleasure to introduce our guest speaker, my friend, Dr. Mohammed Alzunitan. He is the healthcare epidemiologist and infectious disease physician at the Ministry of National Guard Health Affairs. He is also the director of Antimicrobial Stewardship Program and the National Guard. Dr. Alzunitan performed infection prevention and control and antimicrobial stewardship fellowship at the University of Iowa hospitals and clinics. I have been honored to have Dr. Alzunitan as a friend at the University of Iowa, and it's been rewarding to see Mohammed collaborates with international projects. He will talk to us about artificial intelligence, who wrote different skills as a hospital epidemiologist. We have a plan for Dr. Alzunitan to speak for 30-40 minutes, after which we'll have 10-15 minutes to answer questions. You can unmute yourself and ask your questions after Dr. Alzunitan's talk, or you can type your question in the chat. I'd like to ask all of you to answer the survey at the end of the presentation. Thank you, and I will now hand it over to Dr. Mohammed Alzunitan to start. Please, Mohammed, the floor is yours.
Thank you, Professor Alexandre, and it's an honor to be here. I would like to thank you guys for having me presenting a very dear topic to me, which is about the artificial intelligence world and hospital epidemiology in particular. So, you know, one of the most amazing things about COVID-19 is making such a meeting a possibility. I remember like a couple of years ago that having a virtual meeting was not something easy, neither for the organizers themselves or for the attendees. Sometimes it's going to be very, very challenging for people to attend. They're not used to have these platforms and will not have the luxury of me presenting here from Saudi Arabia, moderated by Alex from the United States, and having the audience from Brazil and every country. Here it's like 6 p.m. and it's very early morning in the United States, and I believe it's midday in Brazil, isn't it? So yeah, it's like a different group of the different part of the world just participating in the meeting, and this is one benefit of COVID-19. COVID-19 boosted the field of informatics, especially the artificial intelligence. We have to use a lot of unused tools and being very innovative in our way. There is a booming in the virtual care clinics, for example. Now insurance companies
Mohammed?
It is massive stability if it didn't utilize the disasters in a good way. Is my connection is good, Alex? Or there's an interruption?
There was a brief interruption. We stopped to hear you when you talk about insurance.
Okay. Now, is it good? Is it stable now? Unclear?
Now it's stable.
Okay, sorry for that. My apologies. So the one of the good sides is that the pandemic forcing the insurance company to start paying for virtual care. And that's something very good happened. We know the downsides of the pandemic, and that's really something that we'll remember for a while. So today I'll try my best start talking about the artificial intelligence world. As a physician and hospital epidemiologist, one may say how a physician is speaking about a different discipline, a different field. I'll tell you guys in a moment. Disclosure, I'm advisor for Lean Business Services here in Saudi Arabia. So let me talk a little bit about myself. So I'm trained, I'm internist, adult infectious diseases, trained here in Saudi Arabia. Then pursuing my career, I went to the University of Iowa, where I met Alex, and I was very, very happy and very delighted to meet Alex there. I remember the first day I met him during my fellowship. He was asking me, do you know R? And I said, nope. What is this? It's like a foreign thing that I never learned about. And he was start introducing me to the depth of the informatics and artificial intelligence, especially the machine learning. He was doing kind of projects in that field. And I was start to be amazed about a lot of things. And that's really fulfilled something that I do have. So early on, before me becoming a physician, I do have something for the computers and the codings and etc. I start coding even as a student. I remember my first code is like as copying, these very, very basic codes that you can't find them in magazines or something. And I just was copying, and I think I was using at that time a Java or C++. I forgot which language I was using, but it was just like copy pasting the same code. And it was, to my surprise, when I executed the code and hello world just popped out, it was one of the most rewarding moments in my life. I was like amazed. And I started playing with the code here and there, and I get things displayed differently. And that's when my passion about the computer started in that very early age. I keep building on it. I learned, I started coding afterward. I started learning 3 languages, and I started doing simple codes. And moving forward, I was pursuing the computer science as a career. Then there is a reality check. I'm living in a third world, and the whole thing that I'm focusing on is about the career path. So there is the boost pressure, and there is a lot of things. And I start thinking about the medicine as a field and start liking it. And I said, okay, I think I'm going to pursue medicine. We're so young at that time. We don't know which is which. Going into the medicine, I found another part of myself, the sophistication, and so I just continue studying medicine. I was thinking about quitting it, but then I continue studying it. I still have my passion about the computers, but I just saw it as a hobby. What I can do about it. I'm now going to be a physician, and that's all. After many years, I found people start merging the 2 fields, and the health informatics become a field that we start hearing about. And the first time I was working myself in the health informatics was when I was in Iowa, and I worked with the professors, among Professor Alexander himself, into different projects. And I was really amazed how that field can produce and how that field can be really misused in the same time. So I said, I'm gonna develop my skills as a hospital epidemiologist, and one of the skills, it have to be into informatics and machine learning and artificial intelligence. I have to increase my depth. I went deeper. I attended, I remember me and Professor Lishandri having the same course and Coursera, if I'm not mistaken, with Andrew Ng about the machine learning and artificial intelligence, just to expand our knowledge bases in this field. We want to use this tool. We want to understand this tool, how it's used, because this tool, as good as it is, sometimes can be dangerous when it's not used in a very good way. So that just, sorry about talking about myself a lot, but just to tell you guys about my story. So currently I'm working in the Ministry of National Guard Health Affairs. That's a group of 6 hospitals operating here in Saudi Arabia in different cities. This is a picture of the main hospital that I'm working with. I'm currently the Deputy Executive Director of Infection Prevention Control Program, being promoted recently. I'm taking care of the whole infection prevention and control program activities, including antimicrobial stewardship program in these 6 hospitals. We are also the WHO collaborating centers for the whole EMRO region, which is East Mediterranean region. And also we are the infection control centers for the whole Gulf countries. I'm talking about a lot of very weird terminology for you guys. I'll show you in a minute. So when we're talking about the Gulf countries, we mean all the countries that surrounding Saudi Arabia, including the Gulf, including Kuwait, UAE, which is Dubai, and Qatar, Bahrain, and Oman. These are the Gulf countries, the 6 countries having the Gulf countries union. So Saudi Arabia is the biggest country, and it is in the Asia continent. We are in the somehow in the beginning of the northern hemisphere. So now it's like 6 o'clock in the night. But as you can see, we're having a very distinct features in the country. There is a very high places that even 2,000 meters above the sea level, while there is a very low, and that diversity is having a lot of diversity in the climate itself and the nature itself. So in the south, we have a lot of tropical diseases. We have malaria. We have the Rift Valley outbreak. In the western side, we have the dengue fever, for example, and we're having the outbreak of dengue fever. In the eastern sides, we have a lot of very humid related fungal infection. And then in the north, we're having a very cold winter, for example. And the temperature is, the difference in temperature happening in Saudi Arabia itself, which is not a very big country, to be honest, would range between 10 to 15 degrees. And this is, and in the right side, as you can see, the difference in the temperature and the rain level between the different parts of a reasonably small country. I would call it moderate sized country. The diversity is very massive, from a very tropical side to and I believe we are the only country that they're giving the 2 strains or the 2 type of vaccine, of the influenza vaccine in the same time. We are using the southern hemisphere for the southern part, and we are using the northern hemisphere for the whole country. And because we're hosting the Hajj, the pilgrimage, we're asking everyone to get vaccinated. And you know, we getting people from every part of the world. We're having 2 to 3 million every year gathering for just 6 days and going back. So from October till March, we are offering the northern hemisphere. And after that, by the June, July, we're offering the southern hemisphere. So I think one of the very few countries in the world, if not only one, that offering both vaccines of influenza. So, sorry. Let me start talking about the artificial intelligence and get your attention about the artificial intelligence. This is Alan Turing. In the Turing machine, that's the first principle of computer sciences, and the current computers factors, as he got the father of the current computers and artificial intelligence. It was created to decipher the codes and the encryption that happened in the messaging during the World War. But that evolved to the artificial intelligence that we know. Alan Turing is having the Turing test, which is called the imitation game. And by the way, there is a very beautiful movie about the imitation game and the creation of that machine. I urge everyone, that was directed in 2014. So the Turing test is as simple as that. If an observer observing an outcome of an AI and an outcome of human, and that cannot be distinguished easily, that's an artificial intelligence. So it will have the similar feature of the human thinking and the human intelligence. That's the imitation game or the Turing test. If you cannot easily differentiate a product from a machine, from a product from a human, that's an artificial intelligence. And that's an opposing to the natural intelligence, which is that we have as a human and animals. That's the natural intelligence. So as of everything they having their highs, then they having their winter and their calm area, the calm and the downs. So AI is not an exclusion. So the hype of the AI started from 1950, as you know, most of the theories in the artificial intelligence happened between 50 up to the early 70s. Then there is what they call the AI winter, happened from 1970 until the recent days, or until the 21st century. What happened is the theory remained theoretical because of the computational capacity. We don't have computational power to establish these algorithms. Random forest, support vector machine were very difficult at that time, yet they were created at that time, not yet modified, but it was very challenging to have them having about very practical value. So there is like, and there are some people, they're saying there is like the three waves. So there is the first wave that happened with Alan Turing. Then there is second wave that happened in 80s and 90s, when there is some of the theories that happened related to AI. Then the late one that started from 2005, when we have the supercomputers happening. As a part of from the AI, there is the machine learning. So a machine learning is telling the machine how to think by teaching or giving it a learning material. Then you will measure the product. So, and that's the common thing that we're using, and I'll touch base in the machine learning in a while. One of the application of the AI, which is very important in the healthcare, especially in the hospital epidemiology field, is the natural language processing. In the way that we talk, it's going to be very challenging to understand or grasp the information that we are writing in our notes, for example, in the EHR. So the natural language processing should be capable of abstracting these unstructured data and have them structured that we can utilize and use. Despite the difference in the accent, despite the errors and mistakes that might happen. So that's the power of natural language processing. Perception on the other end is what they call the robot eyes, is the AI recognition, how we are recognizing these items. As you can see, now we're having a lot of the GAN is one of the most famous application of perception. Is about having the ability to understand what you are seeing or what the machine is seeing, and that's having a lot of application with the use of the machine learning, especially in the field of the diabetic retinopathy. The motion The motion detection is very important, especially in the field of hospital epidemiology, and there is a lot of start to be tested about the movement that happened in the patient room and how we can detect this and how we can utilize for example, the 5-mon for hand hygiene. So the machine learning, people are seeing it as a part and subset of AI. Others know they are seeing it as an intersecting part with AI. That's just the very limited part of it. But there is a very good part of machine learning. It's not related to AI. AI related to the pattern recognition, while machine learning is related to how we are teaching and keep this machine learning. One of these tools, one of the synonyms of machine learning, and people are using them interchangeably, is the data mining. Data mining is how we are fishing or looking for data within the resources that we're having. Machine learning, typically, they're having the two types. Supervised is the one that we're supervising the learning itself. We're having the training data, and we're having the validating data, and we are testing it through previously labeled data, and we test the accuracy, we test the area under the curve of the ROCs, the precisions, and the recall, etc. Unsupervised, on the other end, it's something different, like clustering algorithms. We see the pattern that the algorithm is learning, and we see the effect of that algorithm, like using the key nearest neighbor and the clustering algorithm to see, for example, and they've been using this, as I'm going to tell you guys, in for example, the outbreak detections. Email filtering, the way that they see it's including the spam, is one of the machine learning algorithms, very simple algorithm that the emails are introducing. Speech recognition, computer vision, these are very advanced machine learning algorithms, but they're still machine learning. Computer vision, you have to feed the algorithm with data, train the algorithm, then validate that algorithm, then see the result. So that, in the first part, I was just telling you guys about the AI machine learning. Let's start talking about what do we have as an application that already published in the healthcare epidemiology. So COVID-19, it just like boosted the machine learning and AI. So we're having a solution for every part of the COVID-19. There is a published solutions about the contact tracing, how we are tracing them, how we are using the approximation between the cell phones and the physical locations to contact tracing. And that even happened here in the Saudi Arabia. We have an application that's called Tabaad. If you guys in the same room, and one of you is infected, and you've been with that guy more than, for example, 4 hours, once he's infected, that application will tell you that you were with an infected, go and test. And this is how we are establishing the serial and the contact tracing in a national wide. It's having its own benefits, but it's also having its own challenges because, you know, sometimes whenever you are in a building, the location itself will not be very accurate. And yet we can differentiate which one is in the second floor or in the ground floor, for example. So if we don't use the cell phone themselves talking to each other, from using only the GPS, we don't know the exact location of that person, especially the elevation side. And that's the downside of using the machine learning with the GPS and to do the contact tracing. A diagnosis, for example, a lot in the diagnosis is having a lot of algorithms. We teach that machine about these symptomology, especially in the AI, and the likelihood this patient is having COVID-19. Should we test that patient or not? Should we ask that patient to be tested or not? And a lot of similar algorithm be developed and published. Prognosis is about if this patient is having that particular age. And it was very important, especially with the pandemic, and hospitals is having a lot of patients. Sometimes you want to have the prognosis tool who's having better prognosis to direct the resources to, for example. It was very challenging time and very difficult decisions. And we're trying to use the algorithms of the AI and machine learning to help us, to tell us what is the difference in prognosis based on the available data. A discharge, for example, having different criteria. This patient is now clear, he cannot be transmitting the disease. In addition to, because at the beginning of the pandemic, it was very difficult to discharge patient or disposition of the patient from the isolation. Everyone gonna be requiring isolation. So many people try to have different algorithms that when they test them, validate them with the CD value and others in terms of the disposition. And there is so many application of AI in the COVID-19 only, but we'll not spend more time on this. Simulation, because my town and colleagues, they used an AI scenario of MRSA outbreak and influenza, and the whole point of identifying the potentially mitigating interventions, how we can control that by doing just an AI simulation, by seeing how things can happen when you have this outbreak of influenza or the outbreak of MRSA. So, and that can be replicated for any disease that we're having. For example, you can do a simulation for Ebola. You can do a simulation for Nipah virus happening in the hemorrhagic fever, for example. And that can be done by using a simulation, an AI simulation. A prediction, I was very lucky to work with Alex to trying to develop one of the modest algorithm. And in that algorithm, we understand the difficulty. We understood the dangers of developing an algorithm, which is the other side. So the Clostridium difficile infection is one of the most famous because the disease is having a massive financial package with it. It's very costly infection. And it's very transmissible infection. So we want to identify who's at risk. We identify for how long, and we want to predict when they're gonna have this disease or not. So the Clostridium difficile infection is one of the major diseases that we're trying to predict. But yet, regardless, whatever you do is gonna have, even if you have the best model, that model will not be generalized. I will talk about that in a minute. And we used AI in a cluster and outbreak event detections. So we see just the microbiological data, and we run them into a clustering algorithm, and we see the similarities. So, and one of the Langford, that was in 2001, when they run these algorithms, they found there was an outbreaks that happened and resolved without anyone knowing them. And that's expected, that to have an outbreaks. But sometimes we know about the outbreak very late. An outbreak here in my hospital related to Curadoria happened 3 weeks before us knowing it, and the source was chlorhexidine mouthwash, a contaminated chlorhexidine mouthwash. If we have this capability, if we're having an algorithm that every single data coming to the lab will be organized and see if there is pattern recognition, we would know about this early on, rather than just the human observation that we're seeing this organism more than once. What's going on? Because each area is seeing their own patient only. And the micro, for example, the supervisor of that lab for a day is different from the other day. Sometimes it's very difficult to keep track. Unless a non-human algorithms keeping that to very challenging. Screening. So one of the examples that we use AI for screening is using an algorithm to screen chest X-rays for tuberculosis. We know that tuberculosis, once admitted to the hospital, will be not seen or missed. And that will cause a bit of issues inside the hospital. Tuberculosis is an airborne infection that would transmit TB. If we can screen this patient in emergency, especially in pandemic, in endemic, like in Saudi Arabia, we're still endemic with tuberculosis. If we can screen this patient using their chest X-ray, there is a pattern in the chest X-ray that can be detected, and we can isolate this patient early on and screen them. That will be even better. And a lot of screening that are happening, but just this is one example. A treatment, so guiding the treatment, for example, for community-acquired pneumonia, who needed treatment, who need not treatment, based on the definition and the response and a lot of things. They were used by Babri and his colleague, developed in 2020, who were very, very sensitive and very effective. But that was one example. Hand hygiene, for example. There is many applications that use the AI and machine learning, shoe wash, about how much you wash your hand with the sensors and detecting that, and they tell you hand rub with robotic cameras. And there is also a solution that giving you the immediate feedback of how accurate and how good and how thorough your hand rub by using the feedback from these robotic cameras. And the antimicrobial stewardship programs, there is numerous application. So we use the Maring and his colleague in 2021, they used the antimicrobial usage reduction in the encounter level itself. So for example, that encounter of inpatient, the antimicrobial usage most likely gonna be that, or most likely gonna be this. And they see why is that happening, and they're trying to intervene, to utilize or to decrease the usage itself. There is an algorithm to suggest the ASP intervention while on broad antimicrobial. It's collecting the data of the patients and seeing the possibility, for example, using with the accelerated pheno, for example, if the patient is now being susceptible to more organisms, or this patient is having different organisms, this algorithm will run and see if there is a chance of using an hour spectrum, which is a big achievement. One of the usage of AI in the ASP is detection and prediction of AMR. So this patient is most likely going to have AMR or antimicrobial resistance. So we need to use broader spectrum antibiotic from the start. And antimicrobial stewardship programs, not only by using the narrow spectrum all the time, no, by using the appropriate antimicrobial every single time. So detection and prediction of AMR was very helpful into the use and guiding the use of the antimicrobial diseases. Why we need someone who is a clinician, a pharmacist, a nurse, physician, a technologist to start investing into the AI or health informatics. I'll tell you why in 4 points or 5 points. The first point, we believe in the health informatics that if there is a garbage in, they're gonna have a garbage out. So who can I make sure no garbage in is the specialist, is the expert in that field. It's very simple to build an algorithm. It's very simple to train an algorithm. It's very difficult to know if this algorithm is really valid or not. If this algorithm is reasonable or not. So we need people who specialize in the discipline itself and know AI. So they can speak the same language with people who's specialized in the AI. We have a lot of brilliant people who specialize in AI, but they don't know the difference, for example, between E. coli and Klebsiella. They think it's all organisms. So why should care? And what if they don't wash their hands, for example, for the enough period? They don't have the basics that we're having. And I can't blame them. This is not this discipline, it's our discipline. The second, the use and the utilization of these algorithms. If it's not used by non-professional, it will lead to catastrophes and disastrous. The third, healthcare AI is a very, very sophisticated and very, very complex. And people who specialize in AI only will need the help from us to help them understand the complexity of the nature of the diseases that we have. We work as a liaison with people who specialize in AI, us as a health informatician specialized into the medical fields. The fourth, this is the future. The world is moving into this direction, and we need to be ready when everybody is there. And we need to be innovative ourselves and being ahead of the game. With that, I thank you, and I'm very happy to answer your questions.
Thanks very much, Mohammed. Terrific talk. Very interesting. I made a lot of notes, and I have a lot of questions, but I will request if someone wants to ask any question for Dr. Alzunitan, please go ahead. You can type in the chat or you can unmute yourself. To get started, you have some questions. I like very much your talk about the reality or giving the idea of the real world in this scenario of machine learning, artificial intelligence, and how we can navigate in this field for healthcare epidemiology and antimicrobial stewardship. In your hospital, are you applying the artificial intelligence for antimicrobial stewardship program in the antimicrobial stewardship program?
So yeah, thank you for the question. So in the meantime, we still facing a lot of problems in extracting the data itself, because it's not yet really structured data. So once we structure the data and we validate the data, we are thinking about applying a machine learning algorithms helping in this. Once we have the data ready, the problem is still we're facing the difficulty of getting a valid data outside our EHR right now. We are moving in a massive project into the whole hospital about even having a new module handling the ASP to establish the DDEs and DLTs accurately, and because the utilization data is very important, and that will lead to the drug bug mismatch and how we can use this to guide the ASP. So short answer, we don't have any solution yet.
Oh, thank you. And this is important because in Albert Einstein, we have pharmacists and we have like a big data department that are trying to classify data, and as you told very well, it's very hard, to extract data from the electronic medical records. And which tips would you give to these guys to start in this process if they want to finish in using artificial intelligence for the antimicrobial stewardship program?
So once we have, because as I told you guys, you have to make sure that your data are valid and accurate. Once you have valid and accurate data, the door of the algorithms is very, very large and very massive. So we can use, for example, we use the old data of having patients who already, we detect that along their admission, they were having a multi-drug resistance. And we can see which antibiotic being used for that patient. Are they appropriate or not? And we can load them into design algorithm for that. And we can just replicate the same algorithm that's been published. And once we have this data, and this will help us for in the same day, once we have the initial data of that particular patient, for example, most likely this patient will benefit from that antibiotic and this antibiotic rather than these antibiotics. This patient is having very low risk of developing gram-positive. Don't start vancomycin, for example, as a broad-spectrum antibiotic in the beginning. No, this patient most likely will have MRSA. No, please start vancomycin early on. And that's just for the gram-positive and for the bacterial infection. Antimicrobial stewardship involving fungal infections is another era. We know that the fungal infections are moving into the community, and we are starting the antifungal very late. If we're having an algorithm that, and the day one will tell us, this patient is having a higher risk of having fungal infection, I will start this patient on antifungal. I was in service today, and I just started when they called me about a patient on antifungal who was having a fungal infection in the last 3 days. Why? Because they said he just came in from home.
Okay.
We know the candidate epidemiology is changing. People are having it from home. And that unlucky guy was having Candida auris. Candida auris, we know it's one of the very high alert organism in the WHO list because of their resistance to the echinocandins and others. So if that patient was lucky having an algorithm, for example, detecting that he's having the risk factor of developing or having this organism from home, he will be started early on in Infectious B, and her or his prognosis will be better.
Well, I like very much this idea about to use the artificial intelligence to challenge the appropriateness of antibiotic treatment. I think that's a very interesting idea. And for the implementation in your hospital, what is the strategy? You are considering to use this algorithm for the whole hospital or just specific units like ICUs?
Yes. So I'll tell you an example of something relevant that we used in our hospital. We're having a sepsis alert, as most of the hospital are developing and using a sepsis alert algorithms. So first of all, when they want having this sepsis alert and they're using this algorithm, they were starting in a very few areas to start piloting it, understanding the sensitivity of that tool and specificity of this tool. And after validating that, they start rolling on this project, involving the other different units without involving the whole unit, to see the reproducibility of that algorithm. Is that algorithm very specific, for example, for just the ICU patient, or no, even for the general ward, for example? So if you because there is no one size fits all for everybody. So we need to make sure that your algorithm is not underfitting, but not overfitting. It's not for a very particular population, but it's not for everybody. It's not useful at all. So you have to titrate your algorithm until you're having a very good, sensitive enough, but specific enough to detect the sepsis and to guide the interventions early on without just alerting everybody that this patient is for sure is having sepsis while he's coming for just knee fracture, for example. We want these systems to help us rather than becoming a burden. So that's why whenever we are rolling them, we do them slowly and validate them every single time. And we just keep titrating. And this is an endless. You have to keep improving your algorithm. Your patient population is changing. The hospital settings is changing. So there is no fixed solution. You keep changing these solutions to adapt the current situation.
Oh, wonderful. And Mohammed, only for everybody to understand, how is the structure, the minimum structure that we need to do this, to start working? You are a physician. Yes, you are a physician. You have knowledge in health informatics, but who is helping you or giving you the support in the hospital? Who are the guys that you are working?
So previously it was Alex. Now, and now I have to look for someone else. So it depends. It's very important whenever you want to support to improve the field that you are, and this is general, not about just machine learning or the AI, is to not overselling the idea, but sell it very well. Convince yourself, but convince yourself before convincing everybody. This is a beneficial solution, and it is a real solution. And then starting seeking, because if you don't believe it yourself and you just want to sell it anyhow, you wouldn't sell it for anybody, believe me. So just start believing in the solution that you're saying and make sure this is as accurate as you can, as much as you can. Ask for help, gather experts with you. So for example, I'm developing an algorithm to detect the touch areas within the patient rooms. So if this patient is touching this table, for example, how I would know? I'm having 3 researchers from the research center that I am working in, just starting to prove the concept of the change in temperature. Is it a touch or not? Just this concept. which was that's what we call a baby steps. So we just, if I touch this table and there is a transient change in the temperature of that table, is this a touch or not? And how we are validating this by using the approximate sensors within the table. So if that table is touch, that will be our labeling, for example. And we use this concept, very simple concept, to promote for using cameras to enhance the hand hygiene and the 5 moments, for example. So dream large, but start small.
Sure.
Just small steps. I was really fascinated whenever Alex is telling me the story about how the bandit that he's having, about the electronic sanitizers. It was amazing. It was very fascinating. So, and this is how we get the support of everybody. Believe in it. Start small. Prove your concept. Everyone will be with you, and you will be supported. For everyone, from the smallest employee, and there is no one smallest employee, from every single employee in that organization till the highest administration.
Oh, wonderful. But sorry for asking again, because I'm really interested about your antimicrobial stewardship program, because you have pharmacists in the room that are working on exactly in Albert Einstein antimicrobial stewardship program. And how is the structure that you build in this ASP?
Okay, so the current structure that we're having is as follows. We are a 2,000 bed hospital. This is just the central region. We're having 3 ways of conducting the ASP, the restrictions. So we are having 3 levels of restriction, level 1 and level 2 and level 3. Level 1 only for infectious diseases consultant, and that included the very high, the HIV medications, for example, the initiation of HIV medication, the ceftazidime-avibactam, meropenem, vabromactor, the very advanced antibiotics. Level 2 is for the broad spectrum antibiotics. The broad spectrum, whether it's gram-negative or gram-positive. Level 3, the other antibiotic. So each one is having their allowance. For example, level 1, no one can order it. Level 2, you can order it for 72 hours. That's the restriction part. The second part is the respective audit and feedback. We're still doing limited because we don't have enough clinical pharmacists. We have 2 and we're still waiting for more. So we do rounds into the units. We collect the antibiotic usage, and we discuss that with them, and we see the compliance to the recommendation. That's the second part of doing the respective audit and feedback. The third one is the automatic stop order. After the 72 hours, if not renewed, it will stop in 7 days, and for the therapeutic, for the empiric. That's the currently implemented strategy that we're having. We just have one colleague who came back from British Columbia. He's gonna lead the antimicrobial stewardship, and we just have a guy who's leading the pediatric stewardship. Pediatric stewardship, for example, is another story. Now we're having a hospital-wide handshake stewardship. We're doing every single part except the ICUs. They were having the antibiotic review by a specific team. They will see the recommendation, and will follow, and they will give some recommendation, or they follow the recommendation if it's not to be seen by the infectious disease specialist. I hope that answered your question, Alex.
Yes, no, very much, because we have here Gabriele and Tatiana Marins, that offer pharmacists working here, Raquel Queiroz, and other pharmacists that, yes, I think that your answer attended my question, because in our meetings about as I told you before starting this conversation, we have a research meeting. Thank you very much to share with us.
I'm just sharing my email for anyone who's interested to hear more about anything that I'm doing, including antimicrobial stewardship, please reach out.
Yes.
And I will be very happy to answer any question in that regard.
Oh, great. Thank you very much for sharing it, because yes, definitely we request your skills in this meeting, and we Raquel is asking about OPAT, outpatient antibiotic treatment. She wants to know how do you manage this, the OPAT in your hospital?
So I happen to lead the OPAT committee into in the National Guard, and we just finished the final recommendation. So I'll share you what we are currently doing. So we assess every single patient who is in day 3 of antibiotic for the need of OPAT or not. So if this patient is the need of OPAT, most likely going to require this treatment. So we facilitate their discharge and we prepare the OPAT. So we already categorize the medication for stable medication, not stable medication, to be used as an OPAT. We used to have only every 12 hours because of the machine that we're giving the OPAT. Now with the easy pump, we can give even up to Q6 hours. We just educate the patient and he can have the pump with them, the elastic pump, and they can give their symptoms the medication. And we're having our home health care following up with them and seeing the line, if they need to change the IV line, if that's enough, or we insert a big line even before the discharge. We have the infusion unit and we have the daycare unit to manage any possible complication. For example, blocked line or not, things that cannot be managed at home. So the home health care will bring that patient to the hospital and we can manage this thing, and they have physician with them, and people who's covering the infectious diseases consultation service, they're also covering the OPAT. If there is a complication, if there is an allergy, if there is a new bug, they can change immediately the antibiotic without getting into the hassle of the whole thing. So that's the current OPAT, how it's working here at the National Guard.
Oh, thank you very much. Fantastic. Yes, we have a couple of minutes, 3 minutes to finish our talk, but as we are talking before, we want that you work together with you in our research meetings, probably in the beginning of the next year. We invite you to talk about antimicrobial stewardship and how can we work together. I like very much about this idea of using artificial intelligence for appropriate or to decide about the appropriate antimicrobial treatment, because this is a good classification, or we can give something for the computer. We can start, like you said, like small, like working with blood cultures, for example. We have the microorganisms, we have the antimicrobial susceptibility tests, and to make the decision if this is adequate or inadequate in the end, and we can do a supervision method, and maybe we can, validate this with the pharmacist to see if this is what is the percentage of this agreement, and maybe we can think about a cost effectiveness study about that. I think that's very interesting. Yes, and we can start together, because in Albert Einstein, we are starting discussing about that, extracting data from the electronic medical records to do their research projects. And wow, why you can do this using machine learning and artificial intelligence together, and that's what I'm thinking. And I like very much all these other ideas like outbreak detection, because I'm reading some papers about that, and I'm glad that you are using these, like screening the X-rays for TB. That's a very interesting idea, and the contact tracing. I think that's we needed it for COVID-19. I'm reading a book from Bill Gates about how to manage the next pandemic, and in 2 chapters he's discussing about contact tracing for COVID-19, and he was using South Korea skills about that because of MERS, and we know that MERS-CoV, we had a lot of knowledge about Saudi Arabia because all the concepts that we had diagnosis, treatment, and I know that you told me that you are starting a vaccination trial for MERS-CoV, and yes, this is fascinating. I don't know if I have more time for questions, but Raquel, Tatiana, Gabriele, in the chat, they are. Thank you, Mohammed. Really appreciate you stay with us in this Einstein connection. I don't know if, yes, Raquel open the camera. If you guys can open the camera, I appreciate that. Vocês podem abrir a câmera se quiserem. Tatiana, Raquel, Gabriele, all the pharmacists that you are working together. And yes, we hope to see you next year with us in our research meeting. And thank you very much, Mohammed. Oh, and by the way, only for everybody knows, Mohammed worked here. Okay, we worked together. And I feel that you are with me today, Mohammed.
Yeah, I'm having the same feeling, by the way. Yeah, it's like, and that's the beauty of having virtual platforms. It's like really bringing us together. It's just like it's been like yesterday.
And to finish this conversation, like Mohammed started saying that I asked him, do you know R, the R in Portuguese, R program? And he started learning, and in a couple of weeks, I stayed like a beginner, and he's in advanced level. He was teaching me R, doing a lot of graphics, tables. Wow, he's very good. And not R, but Python. He's a master in Python. Java, yes, he started in Java. But all these computational languages, if you show this to Mohammed, yes, it's like a sponge, you know, he gets very, very fast all these languages. And he knows to speak in Portuguese. Sometimes we change some phrases through the WhatsApp in Portuguese. Like Tamara. Tamara, Saudi Arabia is one of the most exported from the world, Tamara. And Tamara is exactly the name Tamara.
Yes.
That's right?
It's true. It's true. Yeah. Just a very essential food that we're having every single day.
Yeah. Okay. But thank you very much, Mohammed. I really appreciate you stay with us in Einstein Connection. And I hope to see you next year in the pharmacy group. Yeah, I hope so. Thank you so much for having me, and stay safe and enjoy your day. Thank you, guys. Thank you. See you very much. Bye-bye. See you. Bye-bye.
Bye-bye.
Take care.
Thanks.